If you'd like to make your statement, and you might want to bring your mic slightly closer to you.
Okay. On behalf of the Patient and Client Council, I would like to thank you for the opportunity to be here today. Empowering people to know about their rights within health and social care is embedded in everything that we do. I thought it'd be helpful to give you just a little bit of background to the Patient and Client Council, then a little bit about some of the work that we've been involved in directly with accident and emergency and where we are today with that work. The Patient and Client Council was established to provide a powerful and independent voice for the public in health and social care, established in 2009, and it has four main duties: to listen and act on people's views, to encourage people to get involved, to help people make a complaint, and to promote advice and information. In terms of listen and act on people's views, we're constantly reaching out to gather evidence and feed it back to the decision makers. And we do that in a number of ways. We have a membership scheme of which we've now got 13,000 plus members, and they're people within any and all walks of life across Northern Ireland. We also use the social media networks, our website, and we're constantly working with community service users and voluntary groups. Over the last 5 years, we've produced 70 plus reports, and in all of those reports, emergency care and urgent care is a recurrent theme. Some of the reports which identified this particularly was a report we did around rural voices, so that was hearing from people in rural communities. Our People's Priorities Report, which is an annual report that we do that just really tries to establish what are the main issues for the public at large in terms of health and social care. Our Young People's Priorities Report, and additionally we produce an annual complaints report, and we have a number of complaints around people's experience of emergency care. After the first a number of years ago, in 2012, there was an incident around emergency care in Belfast Health and Social Care Trust, and at that time we set up a helpline as a direct response to that, and that informed some of the areas where we felt they were particularly difficult for people who were accessing that service. The callers to that helpline told us about long waiting times, not enough staff, and lack of privacy. And while the staff were praised for working well in difficult circumstances, the pressures which that they were working under often and sometimes resulted in lack of communication and a poor attitude towards the people who were receiving care. We encourage people to get involved, and as I say, we do that in lots of different ways, and that's both at individual and a collective group. So working with individuals and trying to get them involved in the work that we do, but also working with groups of people. And some examples of that, particularly around emergency care, is some work that we have done with patients who are receiving chemotherapy and need to be readmitted, and the difficulties that they have about readmission back into hospitals, particularly while they're on receipt of chemotherapy. Also, in terms of getting people involved, we've established local groups in each of the 5 trust areas, and they help us to understand some of the local issues that are for people who are accessing services, and in our role we can help them to take some of those issues forward. We also help to establish the Northern Ireland Rare Diseases Partnership, and we have the Bamford Monitoring Group, which is a group that's made up of people with mental health and learning disabilities, and again that's particularly trying to make sure that people are involved in those particular areas of care. We help over 2,000 people a year in terms of making a complaint and approaching us for advice and information. And in terms of some of the difficulties that we have in Northern Ireland in promoting advice and information is that we currently do not have a credited advice and information service, and we've been actively campaigning for this since 2010, and we've recently got agreement from the Department of Health for a business case for that work. I think it's important just to establish exactly the role of the Patient and Client Council. While the organisation feeds back to the system of people's experience of services, A specific monitoring role in terms of performance monitoring is not part of our remit. That sits within our QIA and the Health and Social Care Board. Since our inception in 2009, people have been highlighting emergency care as a priority for patients in Northern Ireland. And it's reflected year on year in terms of people's top 10 priorities for health and social care. And we constantly are hearing stories from people about their experiences. And we've been working, again, quite hard through our Care When I Needed report to make recommendations to both the Commissioner and the providers of services for ways in which the emergency care might be improved upon for the people across Northern Ireland.
Okay, one more minute,
One more
please.
minute, okay. Emergency departments will always be busy, and they're not the right environment for people with a mental health crisis, long-term conditions, frail elderly, or people with minor injuries who find the long waits increase their worry and distress. It is our belief that the situation will only improve when there's a joined-up approach to the way that urgent care services are delivered. GP out-of-hours services, minor injury unit, and emergency departments must work together with the public to find solutions to the problem of overcrowded departments with excessive waiting times to be seen and treated. The patients who use accident emergency departments and the staff who work there deserve a better service.
Okay, thank you. I'd like to start really with, you mentioned the report you did in 2013, which was Care When I Need It. I think I'm interested in two things. One, if you would just take us through what the key findings were. But then I'm interested in if you tell us about how you followed up the report, yeah, and what response you got from the department, from the board, and from the trusts, so that whether you think the kind of conclusions that you reached in your recommendations are actually being heard or not. So take us through that as well. But if you start with exactly what the report said, and then we'll talk about the aftermath.
Okay, Louise was directly involved in that.
Okay, we went out and talked to people right across the system. We were very keen to make sure that we got as wide a spectrum of opinion on the services as possible. And we used 4 different ways of doing that. We had a questionnaire which we distributed through groups and through our various networks and through one-to-one shopping centres and outpatients departments in A&Es. And we also did on-site visits as well, where we went out and actually talked to people in those various settings. And we had focus groups as well, and in total over 4,000 people contributed to the report. In terms of the key findings, we found that people really want excellent care from compassionate staff. That was the key thing that they said. They wanted to see a reduction time to see a doctor to receive treatment at the emergency department. Many people expressed concern about the safety, cleanliness and comfort of the environment that they were in when they had to wait for long times. They also said that the waiting time for a call back from the GP out of hours was an issue. And for example, if you found you had a sick baby in the middle of the night and you rang the GP out of hours and your baby had a temperature, it was crying or whatever, and you didn't get a call back, well, the thing that the mother will do is get in the car and drive to the A&E. Well, that may not be the most appropriate place for that lady to be with her baby, but that's what happens. That's reality for it. And so we, one of the things we did as a result of this report was we were actively calling on the board and the department to change the callback time for the out-of-hours service. And again, as Maeve has already said, this is part of what we see as the need for a whole systems review. It's not just about A&E, but the whole system needs to work. We find that 92% of people believe that they should not have to wait for more than 1 hour for a GP out of hours to return their call, and 63% would prefer a call back within 30 minutes. We don't think that's unreasonable. We think that would make a big difference if people could get a phone call from somebody who knew what they were talking about within 30 minutes. Communication is a central issue. People often will understand why they have to wait if someone tells them. So this is something that we have been stressing as a result of this report as well. And in fairness, some of the departments, for example, have been very good at improving the communication about telling people yes, we've got a 3-hour wait, and actually doing things like getting people a cup of tea has made a big difference. So there's been a number of improvements even since this report came out and in around the time we were actively doing the work. And some of them are small changes which have made a big difference for people. People will often understand if someone says to them, "You've had a major road accident come in, so we're going to have to wait a wee while longer." That's fine, as long as they know what's happening. So again, communication is really important. Accessibility is a big issue, particularly for people in rural areas. People are very concerned. And for some people who don't have a car or no personal transport, sometimes they get to A&E in an ambulance and then have no way of getting back. Simple things like that. This was also considered to be problematic due to the lack of home visits, which they feel that the GP out of our service, they feel there's a diminishing number of home visits, particularly for the elderly. And people also thought that minor injuries should be more accessible by extending their open hours. And people were very positive about minor injuries units, and when they got there, they got a very good service, and they felt that. And one of the other things that we have been calling for in this report is a good advice and information service. A lot of people, or not a lot of people, but indeed some people who go to A&E, the only service they get is advice and information. But unlike other parts of the UK, Northern Ireland doesn't have an accredited advice and information service like NHS Choices or NHS 24. So one of the things that has happened, and we're pleased to see that it has happened as a result of our work and our engagement with the board and the Public Health Agency, is there's now a tripartite project around establishing a health and information portal here in Northern Ireland. We recognise that a portal is not a be-all and end-all, but it's certainly a good start from where we are at the moment, and we are really actively encouraged by the fact that that is happening, because we see advice and information, accredited advice and information, as being fundamental to people's ability to even look after themselves in these situations. So since we issued this report very widely. We involved members of the Assembly, the Legislative Assembly and the Minister during the launch. We issued the report to all of the decision makers with an extensive communication plan. Every decision maker got the report across the system. And since that, we have been following it up through direct engagement with decision makers when we meet with them, but also through formal correspondence. And in particular, the Health and Social Care Board has taken on board a number of things out of this report and has referenced it in this year's commissioning plan. Now, the commissioning plan is the document, if you like, I often call it the shopping list, which is what actually sets out what the trusts are to deliver. So this year, there's a number of initiatives in the commissioning plan as a result of this report. And with all things in health and social care, it takes time to implement, but we are encouraged, and we think that a number of things have improved. A number of small things that make a big difference for patients are already been put in place. But we think there needs to be certainly a big drive around a more holistic approach to the whole system, because A&E is only part of the journey, and if people can't get out of A&E or can't get into it or are in the wrong place, some of the things that have happened also is the Choose Well campaign. And that's about encouraging people to make the right choice about where they are in the system. Should you go to your pharmacist, should you go to your GP, should you go to a minors injuries unit, or are you best in emergency department? So those are, I'll just stop there, and those a quick run through.
Can I, before I pass you to colleagues, you said there are a number of small things that have made quite a significant difference. A cup of tea was one of them, but can you tell us, just expand on the issues that you think have made a difference? What are those small things that you're...
Simple things like signage and information, improvements in the environment. There's been a number of A&Es that have made simple improvements to the environment, even the seating if people have to sit for a long time, giving people information. Also, some patients with, Maeve talked about the patients with chemo, some patients with long-term conditions like chemo patients, for example. One of the things we've done is we've managed to get agreement to direct access beds, so they don't have to actually, most of them now don't actually come near A&E, and we feel there's quite a few patients with long-term conditions, so people with frail elderly, perhaps who are already known to the system, that there should be a system for those groups of patients as well, where they don't have to come to A&E.
Okay. I'm going to pass you to my colleague Marion.
Good afternoon. I have 3 questions, and they're all on the topic of public participation. And I'm wondering, could you outline for me what your role is in ensuring the public's participation in the development of health policy, or changes in the health care they receive, or how recommendations such as on emergency care are implemented?
Okay, in terms of, take the first one, which is around policy.
Yeah.
Yeah, I mean, I think it would be our view, and again, I think it's very difficult to bottle it and say, you know, that is the change that we made, because, you know, we don't see ourselves as outside, we see ourselves as an integral part of the whole system. But I think it is, we do feel that while we're nowhere near where we need to be in terms of participation, but there is a willingness to try and think, what does this mean for the public? And we're much more around, how would you like it to be, rather than how was it for you? Because we quite often ask retrospectively, well, was that a good experience for you? And it's our view that if you get the public, patients, carers involved in the process much earlier on, that actually what you'll do is design a service that actually reflects what people want, and therefore will be more responsive to what their needs are. And we've done that again in a number of ways. In terms of some of our consultation responses, so when things come to us for consultation, policy particularly, anything that we say is based on what people tell us. So it isn't us saying this is what we think. Our response comes from the evidence that we've gathered from the people that we've spoken to, and that, you know, 50,000 plus people over the period of the last 5 years. So when important things come out, we go to that information, and that's what our response. We think that's really important then about making the policy become more just reflective of what people would like it to be. And again, I think just getting I think sometimes it's not that the service don't want to do it. I think sometimes they forget, or sometimes the speed by which things move doesn't necessarily always allow you for that window of, actually, we need to go out and ask people what they think about it. And I think that we have a really important role in reminding people that they need to do that. Not necessarily always doing it for them, because it's important that the service providers particularly are creating their own mechanisms by which that they do that, but that we're reminding them that we need to do it, and we're also reminding them the quality of the participation, that it can't be tokenism, it can't be kind of one person saying, this is what I think on behalf of a community or a group of people, but making sure that the consultation and the involvement is meaningful and genuine, and is then reflected. Quite often, if we have made a consultation response and then we don't see what we want reflected, then we'll go back and say, actually, you know, where's the piece that we said?
And one of the things that we're very keen to do is to get in at pre-consultation stage with people's views, and over the last few years we've been quite successful in that. For example, maternity service was one, the regional strategy for maternity. And sometimes we provide a voice for those patients who don't have a voice at all. Chronic pain is a good example, where it wasn't on anybody's agenda in Northern Ireland here, and the Minister this year announced it as a recognised long-term condition, and there's now a lot of movement around that in the commissioning plan, for example. That was a voice that was totally unheard in the system. So while we're small, we try to sort of balance our resources on what's coming through for us, but also to identify those groups of patients who haven't been heard at all, or service users who haven't been heard at all in the system, and to prioritise them as well as the big ticket issues. And that's quite a balancing act for us as a small organisation.
Okay. That brings me quite neatly to my next question, which is about individuals who have particular needs, and in terms of the identification of their needs and how you get those to influence policy. You know, children, those with mental health needs, or patients who are elderly. What do you see as PCC's role in helping those people to articulate and to get a better service?
Well, we do that in a variety of ways. Many people come to us as individuals, and sometimes we get individuals who come to us, and then some more individuals come to us, and you start to see a bigger issue. And we do use various ways of participating with people to try to make sure that we are as inclusive as possible, and to reach out to people where they're at and use different means of getting to them. For example, young people's priorities was a piece of work we did with older children a few years ago, again, really understanding what were the issues for them. And again, A&E came up in that as a concern for young people, which was quite interesting. I'll give you an example of where a small group of people, a couple of years ago we were approached by elderly carers who were concerned about being able to plan for the future. They were caring for loved ones who were adults with learning disability, and about the lack of a system to plan for the future. And we were able to, in small groups, get them to meet with decision makers right across the province and right up to the minister. And as a result, there's now much more focus on making sure that people have the right information, that they're supported to plan for the future. And that was actually interdepartmental. That's just not about health. That's about right across housing and benefits and even making wills and all of that. So it was part of our work within Bamford and in the Bamford stream. But so sometimes it influences what happens in other departments. And that's one where we can think right back to an individual to making a change, not only within the Department of Health and within commissioning and within the trust, but also in other departments, for example, the Housing Executive.
My final question is, Maeve, in your introductory section, did outline the processes that you have for consulting with client groups, and I'm wondering, what is your role in trying to collate that information, to identify trends, to bring that to the attention of those who plan or commission the service or the policies, and how you do that and what sort of responses you generally receive?
Yeah, I think it's really important that we are out and about, so we're very much where people are. And we do that in a variety of different ways. But quite often it's literally just about asking the man and woman on the street, what are your priorities for health? What worries you about health? What do you think's good about health? Because I think it's important we don't lose sight of the positive things that are going on and that we're reflecting them also, although it is people are more likely to tell you where they've had a less positive experience rather than a good one. So we're out and about all the time, we're gathering information from people, and it's from that we start to see that these are the things that are important issues for people. And while emergency departments will always be high on people's priority list, there are other things, like Louise described, people with chronic pain, again a bit unheard, but actually in lots of ways, as well as economically, lots of sick time off work, quality of people's lives not being good. So that became then an issue for us. So I think we find out what's important for people, and then we think about how best we can articulate that on behalf, because I think there's a real essence in what we do, in that we have access to people who are making the decisions in a way that people, the average person probably doesn't have. And I think it's part of our role to be that mechanism, and it's about reflecting the stories as we hear them, and not, kind of putting our own spin on them. So I think that's really important, to be true to the information that you're receiving. And then when we have that information, as I say, we use it in a number of different ways. We use it through consultations. We also sit on a lot of strategy groups where we're able to say, this is what we think. Well, this is what our evidence is saying the public think specifically. But where something comes up that we don't have evidence, then we'll specifically go out and look for that evidence around that. And I mean, there are many examples of things that we've had to specifically go out and look to gather an evidence base for. So we're really true to that sense of, we will speak on an issue only when we have an evidence base to do so. We'll reflect what people are telling us, and we'll be true to what they say. And I think that's been very successful in terms of people having the information being credible, and then people then turning to us to say, what do you think? Have you any information about this policy or this piece of work that we're doing? Again, it's very hard to pick up a strategy and say there's the 4 lines, but I think that we're confident that the essence of a lot of the work now does reflect what people are telling us are important to them. And again, I think we'd feel pretty strongly about going back to policy writers to say, actually, you know, that this isn't how people see it.
And would you try to do trend data?
We do in our complaints reports. So when people are coming to us for individual support through complaints, and we've had some examples of that in the trusts around where there's been specific issues have come up repeatedly. We've gone to the trust area and we have said, you have this issue and this is how we can demonstrate it, and trust being receptive to that and trying to make changes to the service based on that. So I think it's taken us a while to get our own databases to be able to do that, but I think we're in a good position now to be able to pinpoint where we're starting to see trends within particular directories of care.
A lot of our, we have been on a development curve, I suppose, with the information and the intelligence that we've been gathering. A lot of our information is qualitative data, and we've a very small team, but we've gradually got better and better at how we analyse that and deal with that, and we've actually brought in some skills in-house because we recognise that we have a huge amount of information which is really valuable to feed back to the system. And one example of that was a couple of years ago, whenever the Minister launched his review of care here in Northern Ireland, we went back and analysed the first 3 years' work, and we summarised that in a document called The People's Priorities for Transforming Your Care. And we were able then to issue that document quite early on in that process to lots of people who had an interest in this, and as a result, some of the things that people actually wanted on the ground came out in the final recommendations of the report, which I think was really important. So by summarising everything that we had gathered over a period of 3 years into one document, decision makers found that really useful. We produce reports all of the time. As Maeve's talked about 70 reports from we came in. What the Assembly members will tell us in the Assembly is they really value the reports when they come in because of the independence of them. We're not a lobby group. We're very much through to what people tell us within the system. And so the decision makers do value the reports, and we get that feedback.
Thank you very much. Thank you.
I'll pass you now to Paul.
Thanks very much for your comments. First, just a small point. You've talked about the health or the absence of a health and information service, and you're lobbying for one. I'd be interested to learn more about it, but rather than take up valuable time to do that now, do you have some, I'm sure you do, have some document which sets out what the proposal is? Yeah. Which you might be able to send to us, and I'd be interested to read it. Yeah. And if that's acceptable, perhaps I can pursue it that way.
Okay. Yeah.
Is that okay?
Yeah.
Thanks. Another question for my sort of understanding the context. The council is based in this legislation of 2009. Just very briefly, I'm very happy you're in existence, but I'm curious as to what happened prior to 2009 which generated this. Yeah. I mean, I think it's terrific, don't misunderstand me. Yeah. But that didn't come out of the blue. There was a political process. Could you very briefly help me understand its provenance?
Yes, prior to the Patient Care Council, and it was really the Review of Public Administration, there were 4 boards, commission boards instead of 1, and each one of them had a council that was part of their board area, and then it was agreed that that should become 1 Northern Ireland wide, and that the legislative powers within that should be strengthened, and the independence just made a little bit more clear, so that although we were part of the system, we were given additional remit to sort of be outside looking in, if you like.
Right. And how many are you? How many is the staff, just roughly?
Okay, about 30.
About 30.
Yeah.
And if I looked at your the money you've been given since 2009, is it going up or down, or plateau?
It's pretty much the same.
Pretty stable.
Yeah.
Mm-hmm. Okay, thanks. That just helps me sort of understand.
Yeah. If you took our budget and you gave it to every single person in Northern Ireland, it works out about £1 per person per year.
Right. Okay. You're a unique organisation doing incredibly important work, and I'd be interested to know whether, apart from the Health and Information Service, do you have any any suggestions, advice on how to strengthen the participatory nature of the health system within which ED is located. And just to elaborate briefly on that, some have said to us, not all, but some have said to us that the system in Northern Ireland is very top-down. It's a very top-down system. But then listening to others, I could see a case could be made that it's not top-down. For instance, there's yourself, there's the council, there are 10,000 voices, there are patient review groups. So I'm trying to get a sense of whether or not, I'd be interested to know whether or not you think it's still rather a top-down organisation within which ED is located. And I'd be interested to know whether or not there are some sort of institutional changes that could be made to strengthen a bottom-up approach if one thinks that's appropriate and necessary. So just briefly, because I have some other questions and time is short.
Okay. Yeah, okay. I think personal and public involvement, as they call it here in Northern Ireland, because we have service users and patients. There's certainly, in our experience, there's been a big development of involvement in Northern Ireland over the past few years, but that requires a cultural change, and I think that's going to take time.
Yeah.
And one of the things we've been thinking about within our own, we're thinking about our next 3-year plan and our corporate plan, and we're looking a wee bit at Scotland, for example, where they have a patient's bill of rights, and we're thinking, is that something that we should be considering in terms of putting involvement on a slightly different level, where we had the patient's charter a number of years ago. That's kind of done and dusted, but we feel that perhaps, and we have the patient experience standards here in Northern Ireland, and we have actually done some work on those, and people tell us they're absolutely spot on, they're the right things to do, but they're not so well known, and we think perhaps there needs to be a next step in the process, which might be looking at what they have in Scotland in terms of.
But those two examples you gave, Louise, I mean, they're really interesting and very legitimate. But if I caught them correctly, they're more sort of normative. They're about standards and so forth. And I'm not knocking standards. However, I'm trying to get a sense of whether or not there is some institutional change that you think it would be helpful to make, rather than another document or another set of standards. So, for instance, do you sit on the commissioning board?
I sit in attendance at the commissioning board. I think if you look, for example, one of the things that Maeve has been actively promoting, and it has made a difference, is if you look, a few years ago, Dr. Foster produced the report called The Intelligent Board, which looked at how participation can, for example, having a patient story told at the board, making sure that board members go out and work on the front line with staff. There's lots of very practical things in that report, and we think that's a very sensible approach, which I know Maeve, with her discussions with chief executives and all, has been actively encouraging that, and there certainly has been that's an approach that has been adopted in many of the trusts, and we think that's really powerful and helpful, and certainly could be improved upon.
Right. What was the name of that again, please?
It's Dr. Foster. It was called The Intelligent Board. It came out post-Francis, I think. Yeah.
So I should look at that too.
If you're looking for practical things that could happen rather than more theoretical things, yeah.
And did you say that, Maeve, do you sit on the commissioning board?
Louise sits on the commissioning
You
board.
sit on the and in what capacity?
I'm in attendance at the board meetings.
Attendance?
Yeah.
So can you say something?
Absolutely, yeah.
Can you vote?
I don't vote in decisions, and I wouldn't want to.
And I'm not disagreeing with you, but why not?
Because I think that would jeopardise our independence. I think we're still, if we were seen to be part of the decision-making process, we're not. We're there to make sure that the voice of the patient is heard, but I wouldn't want to be making decisions which are about commissioning budgets and things like that. That's not my job.
Right.
I think it would undermine our independence.
Right, I follow. And do you sit on the trusts as well? This commissioning board you've understood, you've explained, thank you. What about the trust? Do you sit on the trusts?
Well, we have that opportunity, and in the past some of our staff have attended the trust board, but we're a small resource and we don't go to all trust board meetings.
No. But you have, if you wish to attend, there's a seat for you.
Yeah, we would be welcome, yeah.
I think the opportunity to influence and to be involved is much more than sort of once a month at a trust board, and so therefore there are lots of other mechanisms within the system that we use to kind of make sure that people are listening to what we have to say and taking on board some of our recommendations. So, and in some ways, a trust board's a bit limiting to do that, and success we've had has been around the water cooler moments or other areas where we've taken that opportunity.
I'm not suggesting it should be the only thing, and I'm not sure I'm going to be suggesting it should be developed. I'm just trying to get your view on it. So to go back to my question, and perhaps I interrupted you, but go back to my question. Is there one or two institutional changes that you would wish to see to enhance participation?
I think one of the things that is a struggle for people is navigating the system. So people, and again we would see that in our work, quite often people don't know where to go or what to do, and particularly around ED departments, they become the default position. So people have the information is just not available to make decisions. So, and these things quite often happen in a crisis. So people automatically end up in emergency departments. And one of the things I think is much better working between primary and secondary care, for example, in terms of understanding the alternatives that are available for people and helping people to understand them also. It's our view that people should never be blamed for going to emergency departments regardless of why it is they're there, but because people go there because they don't know what else to do. But in actual fact, the organisations need to make it much clearer about what the alternatives are.
Do you think it's a bit top down?
Yes, probably. Yeah.
But I think it's changing slightly.
Yeah, the culture's changing, so it takes time, you say.
I think if you look at this year's commissioning plan, we can see lots of evidence of stuff that we've put forward on behalf of patients, and it's reflected in the commissioning plan, and there's been a shift over the last 5 years.
I think it's also important to say that on their own, people are not concerned about the length of time they wait in emergency departments. And people understand that actually if I'm there and it takes that long for me to have that care, I'll stay, 12 hours and days. It's the not knowing potentially how long I'm going to need to be there, and not knowing why the wait has occurred that frustrates people. And actually if people find it a good experience for the period of time that they're there, the waiting itself is not an issue for people.
Well, as you say in your report, it's about communication.
Yeah.
And then I must stop with perhaps this last question, just briefly. Do you use explicitly a human rights-based approach to health in your work?
We try to, absolutely. We have worked with the Commission since we've come into being, and I think that's been around trying to get advice about how best to do that,
sure.
And trying to understand
what it means.
Yeah, kind of how that would work best given our organisation. And we have specific examples within our work of where we've worked very closely with the Human Rights Commission in order to make sure that we do that.
You hesitated a bit.
Well, I guess, yes, of course we do, but are we doing it as well as we could, or are there things that we could do better? I think we work with the Human Rights Commission to try and make sure that we do that.
We feel everything we do is about supporting people to have their rights in the broadest sense, whatever that means. And we certainly have made sure that all our staff are trained in human rights and understand the basics of human rights. And where we are, even around individual cases where we have some concerns, we would always pick up the phone and ask one of the lawyers in the Human Rights Office, for example, for a bit of advice on a particular individual case, and we've actively engaged with them as well. So because they're quite interrelated, human rights, and sometimes, but we feel that everything we're doing is about supporting people.
Okay, thank you very much.
Okay.
Maeve, Louise, thank you. As we've said to everybody who's given evidence to us, we are more than happy to take additional material from you, including any further written submission you would like to make. So if you want to augment anything that you've said today, or if you think there's anything that we've missed that's really important, then please feel free to come back to us in writing. And it just remains to thank you for coming in this afternoon. That's been really helpful. Thank you.
Thank you.